Hello everyone. Today we are going to see the uncut video of C6-C7 posterior endoscopic cervical discectomy in a young 25-year-old male patient having left-sided radiculopathy. A young patient, 25-year-old male patient having severe left-sided upper limb pain since 20 days. The upper limb WAS score was 9 by 10. There was a history of excessive traveling few days back. He was not able to sleep at night because of the severity of the pain. His activities of daily living were significantly affected. As far as the motor power is concerned, his triceps was weak, 3 by 5. So this is the MRI of the same patient where you can see there is a soft disc fragment at C6-C7 level. The location of the fragment is paracentral and foraminal. So this is considered to be the ideal case for posterior cervical endoscopic discectomy. So here I have decided to do posterior cervical endoscopic discectomy. So in this particular case I am going to use the stethoscope for the entire surgery. This surgery was done under general anesthesia. The patient was given prone position on the soft headrest. So you have to pull the shoulders down to get the unobstructed view of C6-C7 level. So you can see here I have given slight flexion to the neck, not too much, but there is a slight flexion given. Once you have given the proper positioning to the patients, now it is very important to mark two lines. One line is at the midline, that is the middle of the spinous process. You can mark the middle of spinous process, and second line will be at either spinophacetal junction, or you can mark the line at the middle of the lateral masses. Now this is very important step in cervical endoscopy. Even a slightest change in incision, a wrong incision, can make your surgery very difficult. So when you are taking incision, you can use a spinal needle to mark the trajectory. The trajectory will be parallel to the disc space. So you can use the spinal needle, insert it under the guidance of C-arm, and check whether the needle is going parallel to the disc space or not. So try to target the center of the disc space. Then you can remove the spinal needle and use that spinal needle insertion point as your incision sites. So you can take a stab incision of around 8 mm, again depending on which scope you are using, a stab incision of 8 mm, then cut the deep fascia, and then you can insert the dilator. Again you have to see the entry of the dilator, the course of the dilator under C-arm. Try to target the center of the disc space, and then you can insert a working sleeve, beveled working sleeve, with the bevel facing medially over the dilator. So once you have inserted the working sleeve, remove the dilator, and this is the time you have to again confirm the level of your working sleeve under C-arm, because the chances of your working sleeve slipping either at the upper level or the lower level is very high in cervical spine. So now we are going to see the uncut video of entire surgery here. So this is the endoscopic view. The moment you insert the endoscope, you are going to see the soft tissues over the interlaminar window. So try to coagulate even the smallest vessels here. Whenever you see any vessel, try to coagulate those vessels right away. Once you have coagulated all the vessels, now you can start removing the soft tissues from the interlaminar space here. So the target at this point is to identify the bony landmarks. So the three landmarks which we are concerned about are the superior lamina, then the inferior lamina, and then the lateral mass. So here you can see here, let me orient you again. So 9 o'clock it's cranial, 3 o'clock it's caudal, 6 o'clock is lateral, and 12 o'clock is medial. So accordingly we are now trying to locate our bony landmarks here. So now we are clearing the soft tissues from the interlaminar space, and we are trying to identify the bony landmarks. The most important structure, as you all know, that we try to identify the V, which is formed by the superior and inferior lamina meeting at the lateral mass. So I think the most important step in cervical endoscopy, or any sort of, even in lumbar endoscopy also, is the identification of your bony landmark. Because once you identify the landmarks, the further surgery becomes very easier, because you get orientation, anatomical orientation of everything. So even if it takes a longer time to identify those landmarks, I would suggest take your time, identify all the landmarks, all the possible landmarks, and then start doing the actual bony work. So you can see here, I'm trying to coagulate every bladder the moment I see that bladder. So I'm trying to coagulate it. So whether it is a small bladder or large bladder, try to coagulate that bladder the moment you see it. Because in cervical spine, they bleed like a hell, and certainly it will hamper your vision. So now if you see carefully, at 9 o'clock you can see there is a superior lamina, at 3 o'clock there is an inferior lamina. Right now I am coagulating vessels in the interlaminar window. So now we have exposed the superior lamina, we have exposed the inferior lamina. So I'll do a dissection more laterally and identify the lateral mass and the V, which is one of the most important landmark for the cervical endoscopy. So before starting bony decompression, this is the time you have to again recheck the index level of surgery. Sometimes happen that you may do the entire dissection on the wrong level. So it is advisable to take C-arm sure before starting your bony work again. You can see here we have exposed the V part and the joint also. So you can see here there is the inferior articular process. I am just removing some soft tissue from the inferior articular process to expose the joint more clearly. So now we have completed our soft tissue dissection and identification of the landmarks. Now you can see here the V is very clear, very properly clear. This is the interlaminar space with the ligamentum flavum here. This is the inferior articular process and the joint. This is the inferior lamina here. So you can see the bony landmarks, they are very well identified here. Now we can start our bony decompression. So in this case I am using the diamond burr. So ideally what I do is I start from the superior lamina. Start burring superior lamina, then move towards the inferior articular process. So here I am just burring the inferior articular process. Once you have burred the superior lamina and the inferior articular process, then you can move towards the inferior lamina. So now I'm thinning out the superior lamina as well as the IAP, middle portion of the IAP. So now you can see here the superior articular process is already exposed. So once we complete our bony work at superior lamina and the inferior articular process, we'll move towards the inferior lamina. So we have thinned out the superior lamina and the medial portion of the inferior articular process here. So we'll now start burying the inferior lamina. So now I'm burying the superior margin of the inferior lamina here. So I'll make the inferior lamina thinned out so that I can remove the lamina with the help of Kerrison punch. So here you have to be very careful while using the burrs. These are very sharp instruments and sometimes it slips and goes inside the epidural space. So yes, you have to be very careful while using the burrs. Keep your hand steady. So we have thinned out the lamina. So I'm going to use the side protection burr for the fine tuning. So you can see here we have detached the superior margin of the ligamentum flavum and the inferior margin of the ligamentum flavum. So at this point using burr is very dangerous actually. Sometimes the structures get entangled into the burr. So you have to be very careful while using burr at this time when the ligamentum flavum is already detached from here. So you can see here this is the superior free margin of the ligamentum flavum, which is detached from the upper margin. So now we are using Kerrison punch. So this is the tube sheath punch with very sharp margin. So we will remove the ligamentum flavum, which is already freed from both the margins. And now we are removing the superior margin of the inferior lamina with the help of tube sheath punch. So now it becomes very easy to remove the lamina because we have already thinned out the margins of the lamina with the help of burr. So now I can easily remove the lamina. Again the same thing applies here. Whenever you see any bleeding point, try to coagulate that point right away. So now I'm using the tube sheath punch to remove the inferior margin of the superior lamina, which we have already thinned out with the help of the burr. So now I gradually move towards the medial part of the inferior articular process. So now I am removing the medial part of the inferior articular process. So you have to be very careful. Sometimes the root get pushed dorsally because of the underlying disc fragments. So this time you may end up injuring the nerve root here. Till now we don't know what neurological structures. You have to be very careful here. We haven't exposed the nerve root here. So in cervical spine there is always an epidural membrane over the dura. So you can see here neural structures, they are not very clear. That is because of the epidural membrane here. So we'll just remove the thinned out margins of the lamina. This is the superior margin of the inferior lamina. So once I finish my bony work, so I'll try to remove that epidural membrane, and then your nerve roots and the dura will be exposed. So sometimes this epidural membrane become adherent to the dura. So while pulling the epidural membrane, be careful. So the end point of bony decompression in posterior cervical foraminotomy or discectomy is to expose both axilla as well as the shoulder. So once you see the axilla and shoulder, so that will become the end point of your bony decompression. So now we are trying to delineate the shoulder and axilla of the root. So I don't know whether you can recognize here or not. We are already in the shoulder area, and I will try to delineate the axilla. So for that I have to remove more bone from the superior aspect. Now as I got the complete overview of the nerve root and dura here, I am going to remove the ligamentum fleum, because now we don't need to do any bony decompression. So it is very safe at this stage to remove ligamentum fleum. So it will again delineate anatomical structures clearly. So at this stage you can clearly see the axilla of the root here. I am just burning the vessels in the axilla. So you can already see the disc fragment which was lying in the axilla. But now we have to expose the shoulder area as well. So we'll just go move upwards, remove those soft tissues and the remainder of the ligamentum fleum, and we'll expose the shoulder area as well. Again the philosophy is same. Whenever you see any bleeder, try to catch it. You can see here gradually we are now able to see the shoulder area as well. So here now the root is completely exposed. So we remove little bit of more phloem just for the vision. Actually it is not necessary to remove the entire phloem. Our target in this case was exposure of the root only. So now we'll prepare for the discectomy. So now everything is clear. We have delineated the root in entire length. You can see the axilla clearly, you can see the shoulder clearly. So now just prepare for the discectomy. So you can see here the root is swollen as well as it is tense because of the disc fragment. The first we'll remove fragment from the axilla, then we'll search for any fragment underneath the fragment as well as in the shoulder area. You can see here that is the fragment in the axilla. So with the help of the hook, we'll just tease that fragment. So we are using hook here. We'll just loosen all the fragment. The procedure is more like the lumbar discectomy only, but in the cervical area you have to be very cautious. You are not allowed to retract root or the cord. So use the instruments like hook which can go under the dura or under the root and then explore the fragment from that place. So 2-3 fragments, loose fragments, they are already out. So one more. It's a huge one. So few more fragments they are coming out. You will realize gradually the nerve will become lax. So now I am just trying to get fragment from underneath the nerve root. So this patient had multiple short fragments. I was expecting one single huge fragment here, but the fragments they were coming in pieces. Now this is the I can feel the annular tear here, but we are not going to do anything to that annular tear. We're just trying to remove the free fragments which are free. I still expect there might be few fragments. And this one is the fragment from the shoulder area. So you can see here there was a fragment in the shoulder also, a big one. So there is no fragment in the shoulder. Root looks lax to me. There is no fragment under the root and there is no fragment here as well. So you can see there is an annular tear, but we are not going to touch that annular tear unnecessarily, at least. So I think we have done our job. So now you can see here the root is bit shifted inferiorly because there was a fragment in the axilla. The root was pushed superiorly. So you can see here it is now in the center, more or less in the center. So yes, this is the annular tear here. So no fragment, no migrated fragment. I am here searching for any migrated fragment, but there is no fragment. So here is the image after complete decompression and complete removal of the sequestrated fragment here. The root is completely free. There is no active bleeding. I think this patient will do very well. I hope this video will help beginners to learn cervical endoscopy. We are done here. The surgery is finished. Thank you very much.